Great. First of all, I want to congratulate you for your birthday. I hope you have a nice day. And congratulations to Aymad and Vladimir for these 7 webinars. Uh, I know that the organization of these virtual encounters were really hard and difficult, and I want to congratulate to you.
Thank you.
Okay, thank you very much. This lecture is related to a special keyhole approach through the Trans-Abro approach, performing a supraorbital transciliar for clipping aneurysms, especially for anterior circulation aneurysms. Okay, we will analyze the microsurgical anatomy for the Trans-Abro approach. And I want to thank to Maximiliano Núñez, an Argentinian colleague who helped me with some beautiful dissection of this minimal invasive transcranial surgery. First of all, I want to say again that it's very important, the anatomy, the laboratory training. Some of the dissection that I will show you were made here in Argentina, in Sao Paulo, in United States. And before to operate my first patient through Trans-Abro approach, I was working several months in cadaveric specimens. And this is very important, especially for young neurosurgeons, the laboratory training before to operate patients, especially with new techniques. The preoperative studies are really important, and the preoperative planification when we plan to perform a keyhole surgery is very important. And the surgical technology, of course, because the microsurgical instruments are especially designed for this kind of procedures. It's very important to be familiar with the classical approaches, for example, the bilateral craniotomy, the supraorbital frontal craniotomy, transglabellar, the pterional, the orbitozygomatic craniotomy, and it's important to be familiar too with these minimal invasive craniotomies as supraorbital transciliar approach. And with this kind of surgery, the surgery is possible, of course. We can offer a faster surgery and excellent cosmetic results to our patients. When there are Dr. Pernesky was a pioneer in this kind of keyhole surgeries. It's very important the positioning of the patient, because we need to use the deflection of the head in order to create a straight corridor between the inferior surface of the frontal lobe and the anterior cranial base. Okay, we use the Abro to perform our incision. Generally, we perform a 3 centimeters of skin incision. After to perform the skin incision, we need to dissect the subcutaneous tissue, and our medial limit of our dissection is the supraorbital nerve. It's very important to demarcate the supraorbital canal or foramen in order to avoid the damage of this important nerve. We need to expose the frontozygomatic suture in order to localize our keyhole foramen, okay? Another important nerve that we have in this kind of minimal invasive craniotomies is the frontalis ramus of the facial nerve. And we have these small branches of the facial nerve in the region of the supraorbital transciliar approach. Some vessels we will found here. Here is the medial border of our skin incision. The orbital muscle is retracted inferiorly. We can use hooks only in the superior skin, not in the inferior skin, in order to avoid the damage of this muscle and of course the age. As you can observe here in this dissection performed in the United States, here we have the supraorbital nerve, and laterally, this is the medial border, and laterally we have many small branches of the facial nerve. And this is an important thing to keep in mind when we need to perform these keyhole surgeries, because our incision, after to perform the skin incision, should be laterally to the superior, to the supraorbital nerve, and in a curved fashion in order to preserve these branches to arrive the frontalis muscle in this region. Here, a right dissection preserving the eyebrow. We have here all the ramification of the supraorbital nerve and some kind of connections with the frontalis ramus of the facial nerve. After to perform the incision, we need to expose the temporalis region in order to perform the keyhole foramen. Yes, here behind of the frontozygomatic suture, we need to expose this region in order to perform the foramen. We can use it, we can perform it with 5 millimeters tip of the drill. When we perform this foramen and the craniotomy, it's very important to remove the mammillary eminences of the roof of the orbit in order to create a straight angle of visions between the inferior frontal lobe and the roof of the orbit. It's very important to perform it. The dura mater is incised in a curved fashion with this base inferiorly. And we can see some structures. We can see here the optic nerve, the left optic nerve, the right optic nerve, the chiasm, the carotid artery, the anterior cerebral artery, and the middle cerebral artery, and of course the bifurcation of the carotid artery. Here in a higher visual field, we can observe the carotid artery, the anterior and middle cerebral arteries. And we can approach some special kind of aneurysms using the trans-Avor approach, especially for dorsal ophthalmic aneurysms, for posterior communicating aneurysms located or facing the lateral border of the carotid artery, and M1 or E1 or carotid bifurcation aneurysms. These locations are special for planning this kind of keyhole surgery. Here, it is not a good angiography, but we can observe here the posterior communicating aneurysms facing laterally in the right carotid artery. We try to do angio-CT in the preoperative period and reconstruct the window of the bone that we need to use through this keyhole surgery. And we can observe here the aneurysms in the preoperative study. The surgery starts with a skin incision in the center of the eyebrow. We do this surgery with microscope from the minute 1 to the last minute in order to work with the detailed technique. We use, as I told you some minutes before, some hooks, especially for the superior border of our skin incision. And for the inferior border, we prefer to use some anchoring points in order to retract properly the skin. After to reach the bone, we need to localize this small segment of bone located behind of the superior temporalis line, and only we need to expose the anterior cranial fossa. Yes, the first burr hole, the only burr hole that we use, is located superiorly to the keyhole of the pterional craniotomy. After to perform this initial burr hole, we complete our craniotomy with a drill, and our craniotomy is really small. We have 1.5 centimeters to 2.5 centimeters in the transverse diameter. After to expose it, it's very important, especially for young neurosurgeons, to remove the bone in the inner layer of our craniotomy in order to improve our microsurgical visions after the dural opening. Another point that is very important is to remove this bone located in the inner table in the inferior border, and it's very important to remove the mammillary eminences located in the roof of the orbit. We can observe here some periorbital fat. It is not a problem, not at all. And the dura mater is exposed. We open the dura mater, and we can observe the pole of the frontal lobe in this point. We use the subfrontal corridor using the olfactory nerve as a landmark. This is the olfactory nerve that is a very useful anatomic landmark for reach the optic nerve, and of course, in order to localize the carotid artery. We can observe here the anterior cleanout process, the right orbit, the right optic nerve. This is the carotid artery. We can dissect the carotid cistern, the optic cistern. There is the pituitary stalk behind to this small piece of cotton, and the hypophysis there too. The chiasmatic cistern, the tuberculum cellae, and of course, with this approach, we can expose the sphenoidal segment of the Sylvian fissure, and we can open it if it is necessary to clip the aneurysms in some special cases, of course. Here is the aneurysm exposed. We can dissect the distal neck, the proximal neck of the posterior communicating aneurysm. There is located the third cranial nerve under the carotid artery, and with an angle clip, we clip this small and elongated posterior communicating aneurysm in this case. Here is the aneurysm clipped, and of course the closure in a regular way, as we can observe. Here is the postoperative angio-CT with the aneurysm correct occluded. I will show you the second case in order to sample a posterior communicating aneurysm with the fetal posterior communicating artery. I will advance the video, of course. We perform the craniotomy in the regular way, exactly the same as like the first video. And when we start the surgery, we need to work with all angle microsurgical instruments. We can observe here the anterior cleanout process, the right optic nerve. In this case, it was necessary to open the sylvian fissure in order to expose the whole aneurysm sac. The sphenoid segment of the sylvian fissure is very easy to access and to dissect using the supraorbital approach, not the lateral surface, because it's far from this approach and it is not exposed, of course. We can observe here the carotid artery with the white color. The patient have some cardiac problems before to the surgery, and we can expose the proximal neck, the distal neck of this big aneurysm, and we clip it with a straight 9 millimeters definite permanent clip to this aneurysm. The aneurysm was located inside of the uncus of the temporal lobe here, and we need to dissect the aneurysm in order to avoid the mass effect that the patient suffered in this region. Finally, we can observe here the dome of the aneurysm dissected of the uncus of the parahippocampal gyrus. Once we clip it, we check the correct patency of the posterior communicating aneurysm. We puncture the dome of the aneurysm. We check that the aneurysm was perfectly occluded, and with the microcisor, we opened the whole aneurysm in order to avoid the mass effect that her temporal lobe suffered with this aneurysm. And here we can observe the internal surface of this aneurysm in this case. Here, the internal surface of the aneurysm perfectly occluded. This is the angio-CT in the immediately postoperative surgery with the posterior communicating artery with correct patency. The patient in the postoperative period, of course, the cosmetic results were good. The frontalis muscle was perfect too. And the last case I want to show you is this carotid bifurcation aneurysm. We planned the surgery with the angio-CT. It's very important for us in order to reproduce a real scenario like we will have in the surgery. This is a short video where we can observe the incision through the eyebrow. The dura mater exposes is really small. We can observe here the opening of the dura mater of the frontal pole in the same fashion with the base in the orbital rim. The inferior surface of the frontal lobe, the left optic nerve is exposed here, of course, and we need to dissect the sphenoid segment of the sylvian fissure in order to expose properly the carotid bifurcation in this case. This is the carotid artery, the third cranial nerve, the middle cerebral artery, and the anterior cerebral artery, and with the right 9 millimeters permanent clip, we occluded this carotid bifurcation aneurysm. Here we have the preoperative angio-CT and the postoperative angio-CT. Some interesting comments about this kind of keyhole surgery. The surgery was, the duration of the surgery was 19 minutes. Only one clip cost $100, and 2 days in the postoperative period. And after that, all the patients received the hospital discharge. Finally, I want to share with you this interesting paper that we published some months ago in interdisciplinary neurosurgery about supraorbital transciliar approach for posterior communicating aneurysms in a 3D surgical video. Thank you very much, Imad, Vladimir, for your kind invitation.
Thank you very much, Matias, being on time. We'll give a chance for one comment or question. Toward the end of the day, people, they get depleted from questions because they are ready for either to sleep or for dinner.
Can I just mention?
Yeah, Ramesh.
Thanks, Matias. That was a great talk, and the slides were superb, including the videos. What is your technique to deal with a very well pneumatized frontal air sinus? How do you seal it off?
Thanks, Ramesh. If we have a very pneumatized sinus, when we perform the craniotomy, we need to treat the sinus as a regular way we use with the pterional or frontopterional craniotomy. Yes. Sometimes we need to open the frontal sinus and we remove the mucosa and we treat it with muscle or with bone wax.
Okay, thanks.
I think it's an important point when you go, as you mentioned, lateral to the supraorbital nerve. The chance to enter the sinus is remote unless you have an opera singer that he has a big sinuses. But being lateral to that nerve, the chances will be less. We have published about 20 years ago 16 cases using this technique, but we added, we use it for even for supracellular tumor, but we added taking the rim of the orbit as we are doing a mini frontoorbitozygomatic, and we put it back. But thanks for Dr. Pernensky, who has introduced this subject. And it depends. Some people, they don't like to have a scar in the eyebrow, but you showed fantastic cosmetic results. In my series, they were not always nice cosmosis. And if they are bald, this is the preferred incision for them. But if they have hair, I'm talking about supracellular tumors, they don't mind to have the hairline incision. Thank you very much. Any other comment or questions?
Thank you, Imad.
All right. So